Mute server. There we go. Okay, can y'all still hear me?
Yeah.
Okay, perfect. Okay, so we're going to be starting with National Registry for EMTs, care of patients during resuscitation. It's a fun topic, everybody's favorite topic, CPR. A little about me. My name is Brad. I've been an EMT for going on, actually just hit 13 years, and I've been an advanced EMT for about a hip 2 years. I have been an Air Force medic for 13 years, and I've been teaching for the past 6. For the past 2.5 years, I was teaching with the Army EMT program, and now starting tomorrow, I'll be teaching with the Navy Corpsman program, teaching them EMT, TCCC, all that fun stuff. Education is one of my passions, and that's kind of why I left active duty to go teach full time. So let's see here. Make sure this works. Oh, fantastic. It's working good. So these slides I made with AI because I asked for all the data so I can compile it very easily. And then I just added all the fun pictures and organized it. Let's see. Okay, so those are learning objectives. I'm a military guy, so we always have our learning objectives at the beginning of the slides. That's what they are. We're talking about the guidelines, CPR, airway, resuscitation, airway management, and pharmacology as the primary objectives we'll be going over today. If you all have any questions, please feel free to ask. I am an open book except when the book is closed. What? Okay. Okay, skipped over some slides randomly. So here we go. This is the chain of survival. Chain of survival does not change per EMT basic or advanced EMT guidelines. I'll primarily be focusing on EMT basic initially, and then near the end, I'll be adding on to the advanced side where the pharmacology and the more advanced airways. So the AHA and registry recognizes 5 chains for the chain of survival with early recognition activation. Hopefully that's where bystanders recognize shit's hitting the fan and they're like, oh shit, we need help. Let's go ahead and get some 911 on the way, and that's us. Woohoo! We arrive and hopefully save the patient. That is our goal. The hands-on actually starts with early CPR, followed by rapid defibrillation with an AED if you're trained to do so, and then basic and advanced EMS systems or services and advanced life support / post-cardiac arrest care. And then the Red Cross likes to add a 6th chain to this called recovery, because recovery from cardiac arrest is a lifelong process. I've had a few friends and family members that have experienced cardiovascular incidents. Luckily, no cardiac arrest, but they are still recovering from it, along with stroke-like symptoms, which is fantastic. Not for them, not for me either. Let's see here. And to confirm, Katie, you are currently an EMT, correct?
Just got my AEMT.
Just got your AMT, fantastic, even better. Okay, so foundations of high quality CPR. The rate or the speed of it never changes. The rate or the speed, how many compressions per minute, does not change. It will always be between 100 and 120 compressions per minute until a guidelines update in the next few years and they realize, let's go slightly faster or slightly slower, because about 10 years ago it was 100 and now it's 100 to 120 compressions per minute, which to me makes sense. For those that are taking tests soon in the future, or maybe taking tests with Red Cross or AHA, pay attention to the depth right here. Okay? Depth is important. Because for adults, I repeat, for adults, which is recognized by the onset of puberty and above, you need to compress the chest to at least, I repeat, at least 2 inches, or 1/3 the anterior posterior diameter of the chest. So front to back, about 1/3 of that depth for anybody following along online. Okay, so that's for adults or adolescents and above. So for those or for those people around age 13 to 14 to 15 that have gone through puberty. Signs of puberty is when we start to identify them as adolescents, and we treat them the same kind of criteria for CPR as adults. So at least 2 inches in the depth for chest compressions. For children, this is important. For children, it is age 1. I repeat, age 1 or 12 months to onset of puberty. That's for children. The depth compression is about or approximately 2 inches, not at least, about 2 inches. The Red Cross is very specific in that verbiage, and make sure you pay attention. What's up, Jackie? I see you popping in the chat and my TikTok. I'm also, let's see here. So at least or about 2 inches for children, which is age 1 to onset of puberty, which for males is underarm hair growth and for females breast development. Okay, for infants, which is birth to age 1. Yes, you guessed it, age 1. Birth to age 1 is about or approximately 1.5 inches. Okay, about 1.5 inches for infants, which is up to 1 years of age or 12 months. Very important to know those factors. Okay, let's see here. For chest recoil, recoil means allowing the chest to fully go back to normal shape after you compress it. Okay, normal shape after you compress it. You need to allow it to fill back up. Imagine it's like a toilet. If you don't allow the toilet to fill back up completely, it's not going to flush properly. Same thing with the heart. If you do not allow it to fill completely with blood, it's not going to flush properly. It's not going to pump properly. You're not going to get good circulation and adequate perfusion, which is the goal of CPR. CPR does not restore vital signs. CPR is to keep the brain and the vital organs perfused, which means full of good oxygen and nutrients and removal of waste so your body can actually survive. So you need to allow that chest to fully recoil between each compression or go back to normal shape. After you compress it, go back to normal shape. Compress, back to normal shape. Oh, my neck. Sorry, I just got off 7 days of work and I have another 5 days in a row right now coming up, so I'm exhausted. If for any reason you need to interrupt chest compressions, i.e., for example, switching compressors, ventilating, or hooking up your AED, you should keep the interruptions to less than 10 seconds. Less than 10 seconds. It does not take that long to provide ventilations or to hook up an AED. You need to be quick and efficient if you're using it. Am I going too fast for anybody, or is this a good speed?
No, it's a good speed.
Okay, sweet. TikTok folks, for Jackie, who I'm assuming is still hanging out there, is this a good speed, or am I talking too fast? Let's see what they think, since we're just starting anyways. See if she responds. She's one of my buddies from like the past year and a half that's been a friend on TikTok and social media shit. Hello, hello, teaching about CPR resuscitation for EMT basics and EMTs, even though we don't call them EMT basics anymore, per registry guidelines. Okay, so moving on with the ratio, that is comparing compressions to ventilations. Compressions to ventilations is our ratio. So for adults, if you do not have an advanced airway, which means a tube that goes all the way down the throat, if you do not have an advanced airway, it is 30 compressions per 2 breaths, or per 2 attempts at breaths. 30 adequate compressions per 2 attempts at breaths. If your first breath is not, we'll talk about this breaths in a second. For children and infants, if you're by yourself, it is 30 to 2, 30 compressions with 2 attempts at breaths. But if you have two or more responders, it is 15 compressions per 2 breaths. Any of my students know why we do that? Anybody know why we changed 15 compressions per 2 breaths for children and infants? That can go for the TikTok or the Discord friends. See if anybody wants to take a shot in the dark, even though it's pretty bright in my room.
Just to get help with the oxygenation, since children are more dependent on oxygen than adults.
Fantastic. 15 points to Gryffindor. Fantastic. So children and infants are more dependent on ventilation / oxygenation support, since the primary reason that children and infants go into cardiac arrest is due to respiratory failure or arrest. So we need to provide more effective and efficient ventilations for these children. So that's why we switch to 15 compressions per 2 breaths when we have 2 or more providers. Let's see here. I keep seeing things pop on my other screen, so it's distracting me a little bit. Okay. Oh, but Mr. S or Heathen Medic, whatever you want to call me, just don't say my last name if you know it. Why don't we switch to 15 to 2 with adults? What do you think, Katie? Do you know why we don't switch to 15 to 2 for adults when we have 2 or more responders? See if she's awake.
I am awake, I swear. Sorry. I was writing stuff down.
Oh, okay. Okay.
What's it called? So would it kind of go alongside with when you said that they were for children and infants, they're more dependent on ventilations, and as for adults, they're it's more of the compressions?
Yes, that's the primary factor, and let's build off that though. So, have any of y'all been on a farm or had one of those hand pumps on the farm where you had to pump it to get the water flowing? Or
No, but I've seen them.
seen those? So those things take forever to get the water flowing. They take a lot of pressure built up to get the water flowing effectively the through the pump so it can flow out. Think of that same kind of concept with adults. Adults have much bigger bodies typically. NRMT tomorrow. Hopefully you pass. Good luck, Roman. I'm going to pause for a second for the lesson and talk to Roman for the NRMT. NRMT focuses a lot on primary assessment. Okay, assessment skills. So knowing the order of operations. What's going to kill your patient first? Fix it, and a lot of mix and match. So select the best answer. I am echoing. Thank you, Roman. See if I can fix that real quick. Let's see if I can figure out how to fix that shit. Echo check. Hello, hello. For Roman, I'm also on my a Discord server with some EMS folks. There's no echo found. Let's see what it says here. Stop noise suppression. Hi. I had an issue before with it doing that too, so I had to figure out what's going on. Audio effects. Let's see. Roman, is it distracting or is it decent? Let's see if they say. No sound. It's okay? Okay. Can y'all hear me still? Making sure it's good to go. Okay, so it
We
killed.
can still hear you.
Perfect. So NRMT focuses on primary assessment organization, what's going to kill the patient first, and a lot of mix and match, as well as select the best answers that apply. So as I was saying about the chest compressions for adults, it takes a lot more compressions, about maybe 10 to 12 compressions, for blood to be circulating profuse good through the body. So if you stop after 15, you only got like 3 to 5 good compressions in, versus for children, it takes maybe 3 or 4 for the compressions to be adequately perfusing the body, because it's a lot more tissue to perfuse for adults. So that's what I always tell my Army students and now future Navy students starting next week, to make sure you think of the size difference. Let's see here. So ratio 30 to 2 for everybody if you're by yourself. Adults is always 30 to 2 unless you have an advanced airway, and infants and children or pediatrics is 15 compressions per 2 breaths if you have 2 or more responders. For advanced airways, that does not include OPA or NPA, which is oropharyngeal airway or nasopharyngeal airway. If it does not go past, or if it does not meet the glottic opening or go past it, it is not an advanced airway. The glottic opening is where your vocal cords and your epiglottis kind of rest, like a little flapper with two little V's opening up. If it does not meet that opening, it is not considered an advanced airway, or does not go past it. So those are basic airways. If you have a basic airway in, you will still do the ratio 30 compressions per 2 attempts at breaths for adults. Let's see here. That's how the ratio will be. If you have an advanced airway in, you would do continuous compressions. It means you don't stop. It means you don't pause. You do not pass go. Do not collect $200. Continuous compressions with one breath every 6 seconds. And make sure if you are the one ventilating the patient with that advanced airway and the BVM hooked up, make sure you're not squeezing the bag at the same time someone is compressing. Wait for them to compress the chest. As they come up to recoil the chest, you squeeze that bag, or else you're fighting against the compression. It does not work. It does not work well at all. It's not going to be effective. You're going to be losing out on a compression and a good ventilation. So it's one breath every 6 seconds with continuous compressions if you have an advanced airway. Now, Roman, since you're in the chat now and you're followed me and gave me a lot of over 300 likes so far, maybe you can answer this question. Why do we only give breaths until we see the visible chest rise? Why is that our goal, to only see visible chest rise? Let's see if he wants to answer and see if he can do it. He's an EMT student and he's taking registry tomorrow. For one of my Discord friends, can you put the link? Actually, I can grab the link real quick. I can put the invite. Means you're adequately providing O2. Yes, that's part of it, Roman. To build off of that, if you squeeze any more, you may fill up the lungs too much and compress the chest, which may reduce cardiac output. Which, as you know, cardiac output is heart rate times stroke volume. I'm getting the invite for the Discord server. I'm going to add it to gastric distension too. Absolutely. Gastric distension or insufflation can occur. And I'm adding a Discord server for you, Roman. It's for Medics After Dark. It's for Nightmare Medic. He created this a while ago with some friends, and we teach a lot of people and have good conversations in here. As long as you behave, you can join. There we go. Okay, so excessive, which means too much air, and hyperventilations, too fast, can cause gastric insufflation. Absolutely, Roman. And gastric insufflation or gastric distension, air goes into the stomach because it can't make any more air in the lungs, or can't push any more air into the lungs, as well as the lungs kind of squeeze the heart, so it cannot move as well. It's going to reduce cardiac output. That's why we only give breaths until we see the chest begin to rise. Begin to rise. When you place your hands, I don't see it on the slide, but one hand on top of another, I found it's easier to put your dominant hand on bottom closest to the patient's chest. Interlock your fingers and pull the hands or fingers off the chest. Make sure this little crease in your hand around below your thumb and right around your wrist, I like to get that at the nipple line on the sternum, which is the lower half of the sternum, right around the nipple line. Make sure when you are doing compressions, your shoulders are directly over your palms and your elbows are locked out. So you are using your body weight and weight to compress the chest and not your arms. You're not trying to do tricep dips. And for those that have seen Happy Gilmore, great movie, Happy Gilmore and Happy Gilmore 2, it's all in the hips. Okay, it's all in the hips. It makes that fulcrum at the hips to compress the chest to at least 2 inches for adults, about 2 inches for children, and about 1.5 inches for infants. Questions so far? Anybody? Roman, how are we doing? You sent a dolphin? What the hell? Thanks, Roman. I have no idea what that means, but thank you. Let's see here. And anybody on the TikTok live, if you join the Discord link in the server, you have questions, please ask them in the questions area after you select a role and introduce yourself, so we know you're not a bot or some kind of troll. And a lot of our EMS providers here are excellent teachers and can explain things very well, so the more the merrier for joining our Discord server. So any more questions on how to actually do the compressions itself before we move on to the airway issues? You said ice cream cone too? What the hell? I got ice cream coming in? Okay, okay. Thanks, Roman. Oh, geez. I don't know how to react. I don't do well public praise with the gifts. Okay, so moving on. Let's see here. Airway management for basics. Okay, airway management. Open the airway. If there is no head tilt chin lift, sorry, if there's no suspected head injury, which if you're worried about CPR, you're probably not worried about doing a jaw thrust or holding C-spine. In all honesty, it's really hard to hold C-spine and do compressions at the same time. I'd rather save the life and have some spinal issues versus not be alive. So head tilt chin lift is literally you're putting two to three fingers on the forehead and the other hand on the jawline and tilting the head back and lifting the chin. It's in the name, head tilt chin lift. Oh my gosh, it's not overcomplicated. And that's for non-suspected spine injury. If you suspect a spine injury and you have time to do it, you can do a jaw thrust, which a jaw thrust is literally giving them a massive underbite. You're literally giving them an underbite. I can't really demonstrate now because it's hard to demonstrate on yourself. And I also have the filter on the background, so you can't really see my hands too well. But all you're doing is tilting, or all you're doing is giving them underbite. You're grabbing the backside of the jaw and making them a bulldog, pretty much. If you need to suction, which is very possible, especially if you use excessive ventilations or hyperventilations or overventilate, they may vomit, or if you had some kind of overdose issue, you may see vomit in the airway. Make sure you use a suction device to clear it out. Okay, suction device to clear the airway before you start to ventilate. Because if you try to ventilate with fluids, blood, vomit, or secretions in the airway, you will cause them to aspirate. You'll force all that gunk down into the lungs, and now they're going to get an infection and possibly die. So don't do that. Sorry, possibly be unalived per TikTok standards. Ooh. For the adjuncts, you can use the OPA or the NPA. If they are in cardiac arrest, most likely they do not have a gag reflex, but they might still have a gag reflex, so be careful of that. So how do we check for gag reflex? If they have a painful response, they probably have a gag reflex. So for OPAs, you measure and insert the OPA from the corner of the mouth to the angle of the jaw, the earlobe. Anywhere in this range, from center mouth, angle, corner of the mouth to angle of the jaw or the earlobe, will really pretty much work. Okay, I'm not going to teach you how to put airways in. I'm not going to go over that today because this is about resuscitation basics. If you think there is a gag reflex, but no basilar skull fracture, which is the base of the skull. Oh my gosh, it's in the word basilar, base of the skull fracture. If there's no suspected basilar skull fracture, you can use MPA, nasopharyngeal airway, which goes in through the nose. Maybe one of the other medics in our Discord will host an airway adjunct lesson later on in the next few weeks. Be great. And then you ventilate using the BVM bag valve mask. It's in the name, BVM bag. It has a valve, and it has a mask. You're going to squeeze the bag about halfway until the chest begins to rise. How are we doing so far? Any questions? Am I going too fast? Is this too complicated for anybody on Discord or on a TikTok live? Because folks on Discord are already medics. Let's see here. Okay, let's move on. Here's the O2 device. You can either have this canister or one hooked up in the ambulance, depends on what your unit has. Make sure you set the proper flow rate. If you're using a BVM, a bag valve mask, you must set it to at least 15 liters per minute for the oxygen flow, which means 15 liters of oxygen will come out of that O2 canister per minute, liters per minute. Let's see here. Signs of effective ventilation. You're going to see chest rise, improved skin color. So look at the skin color condition temperature, CCT. If you have a child, you'll see the heart rate improve. A low heart rate in children is bad. A low heart rate in children is bad. Also, make sure you use capnography, which we'll talk about later on. Nothing too complicated with oxygenation. It goes along with ventilation. Because if you're ventilating, then you should have oxygen if you are an EMT. Let's see here. Defibrillation. Now I get into the memes, because I like to put memes in my slides. Defibrillation. AED or manual, as in for the basic layman's course we're talking about the automated external defibrillator, AED, automated external defibrillator. So it is sensitive for two different rhythms. These are the shockable rhythms, the ones you see here, ventricular fibrillation and pulseless ventricular tachycardia, more commonly referred to as just VTAC. VFib and VTAC are the common names for these. VFib, VTAC. You're probably going to hear more specifically pulseless VTAC, but most people just call it VTAC if they're in a cardiac arrest. Let's see here. Follow the prompts of the AED. Just turn it on. It will tell you every single step of the way. If you are gassed out of your mind, you have no clue what's going on, you're scared shitless because you're a lay responder or it's your first call as an EMS provider, just follow the prompts. It's not that challenging. Okay, let's talk about those cardiac arrest rhythms real quick while we're on this topic. So there are 4 primary cardiac arrest rhythms that you may see as an EMT. 2 of them are shockable and 2 of them are non-shockable. The 2 shockable rhythms, as previously announced, was VFib, or ventricular fibrillation, or ventricular tachycardia, VTAC, more specifically pulseless VTAC. So the AED senses and analyzes those rhythms and tells you to shock them if it is one of those 2 rhythms. Now, I use a lot of toilet analogies when I teach cardiac arrest. A lot of toilet analogies when I teach cardiac arrest. So think of the heart like a toilet. Mentioned it earlier with the recoil, but each time you flush that handle, imagine that flushing the handle itself as electrical impulse in the heart. Imagine the flushing the handle, electrical impulse in the heart. Every time that flushes, it activates something in the back of the toilet to actually manually open the valve, activates that chain, pulls that chain up, which opens that valve to allow water to flow through the toilet. Same kind of concept in the heart. Each time you flush the handle, the valve opens and allows water to go through. Each time the electricity goes, tells the heart to contract, pushes blood through. So if you're flushing the handle way too fast on the toilet, it is not going to flush properly. That is called VTAC, or pulseless VTAC, because it's pumping too damn fast for the heart, not organized enough, too damn fast, and does not allow the heart to fill back with blood, which reduces cardiac output and puts it to kaput, puts it to 0. So now you're not going to be able to you're not going to be able to feel a pulse. What's up, man? What's up, BSI Scene Safe 69? Just doing a lesson on resuscitation on the Discord server. I'm not sure if you're part of it, but I'll post it again here for y'all. Just make sure you behave if you join the Discord. Answer the questions appropriately. It's called Medics After Dark. Medics After Dark. Behave in the server. There we go. Okay, so VTAC, you're flushing the handle way too fast. You're flushing the handle way too fast on that toilet. The heart's beating way too fast for the blood to actually effectively go through. That is VTAC. Now, what happens if you just jiggle the handle on the toilet? Why would you just jiggle the handle on the toilet? That is right. It is not organized or strong enough to actually tell the heart to or to tell the valve to open up in the back. Same kind of basic concept with the heart. It is not organized enough to tell the heart to contract to push blood through. You guessed it. That is an issue with electricity, which is VFib, ventricular fibrillation. VFib, ventricular fibrillation. Both of those rhythms are shockable. I know, shocking, isn't it? Well, hopefully you will be shocking them. Yes, I make a lot of dad jokes. It's okay. You'll survive. Let's see here. Heck yeah, man, it's awesome. Both are yeah, absolutely. Both are shockable rhythms because it is an issue with electricity. Electricity is acting up. What the AED will do is realize something's wrong with it and kind of freeze it. Pretty much tells it shut the fuck up. Oh, sorry, shut the frick up. Stop going too crazy, and reset. It gives the heart a chance to fix itself. That's how I explain it to my Army students, at least, and soon to my Navy. Okay, the 2 non-shockable rhythms. The 2 non-shockable rhythms are BSI Scene Safe 69. Do you know the 2 non-shockable rhythms? Let's see if he wants to participate. Let's see if he wants to help out. I'll give him a second to type. Do 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 do. Ba ba ba. Asystole and AFib. AFib not directly, but asystole is one, and the second one is Anybody? PEA, pulseless electrical activity. Those are two other cardiac arrest rhythms which are non-shockable. Now here's the toilet analogy for y'all. Oh yeah, PE, you're good, man. You're good. It's one of the more forgettable ones that we talk about. At least my students forget about it all the time. So with asystole, the toilet analogy to help y'all memorize what's going on. You ever take a giant ass shit and you're just looking at the toilet hoping it flushes? That's what's happening in the heart. You're not doing anything. You're not flushing the handle. Mechanically, it's not moving. Nothing is happening. You're just praying to whoever God or God you worship that it flushes, and it's not going to do it. That's asystole. The electricity, no mechanical movement of the heart. So if you shock it, it's not going to do shit for them. There's nothing wrong with electricity. It's not going to work. So don't do it. You're going to cause more damage to the patient if you do that. And then PEA, pulseless electrical activity. Pulseless electrical activity is PEA. That's when you're looking at the rhythm. Electricity is just fine in the heart. Electricity is just fine in the heart. If you're looking at the EKG, you're going to see the rhythm. It looks normalish. It looks quote unquote normalish. But you're not going to feel that pulse when you check the carotid or the femoral pulse for the central pulse. The toilet analogy I use is imagine you're flushing the handle on your toilet, but the chain was detached from the, what's that? Oh, B-Town Fury, you joined the TikTok, appreciate you. Your chain is detached from the handle on the flapper. So each time it flushes, it's not actually opening the valve. Electricity is working just fine, but it's not connected. There's some kind of disconnect. So if you try to shock this, it's going to mess it up even more so. So don't do that. If you see a rhythm, don't shock. If you see a normal-ish looking rhythm, don't shock them. So those are the four cardiac rest rhythms which are most commonly seen and basic ones we talk about. Two are shockable, ventricular fibrillation, and pulseless ventricular tachycardia. Think of V for voltage, VFib and VTAC. V for voltage, you need to use electricity to shock them. And asystole, nothing's happening in the heart. And PEA, electricity is firing, but there's no connection. Appreciate the follow there, B-Town. B-Town, bum bum, bum bum, bum bum. Okay, so if you're using an automated external defibrillator, it will tell you if it's shockable or non-shockable. It will say shock advised, charging, don't touch patient, hands off, I'm clear, you're clear, we're all clear. You should also do that while it's analyzing heart rhythm because you don't want the AED to pick up your electrical rhythm or any kind of movement on the patient, thinking, oh my gosh, they have a heartbeat, when in fact they don't. So hands off, I'm clear, you're clear, we're all clear. Visually look up and down your patient because you may have, if you have some bystanders in the back, they may accidentally be touching the foot and you're not paying attention, and now you're going to have two or more patients, which if you only have two people drive in your ambulance, there's one driving and one in the back. It's kind of hard to do compressions on two people at the same time. Just saying. It is not fun. You're definitely going to get a real workout there. So you're going to analyze, stand clear, I'm clear, clear, we're all clear, shock advised. If a shock is advised, some AEDs allow you to do compressions while it is charging. Some AEDs do not. Depends on your local protocols and what kind of model of AED you have. If you're using a Zoll, Life Pack, etc., probably going to be doing compressions because you are in charge of pushing that button on those two models. So once it starts to get ready to shock, you'll clear again. You don't want to shock anybody else and or yourself. I've heard studies of EMS operations in Europe going over. One second, what's this? Sorry, I just got a text from one of my bosses. It's all good. I'll text her back in a little bit. Was it the EMS operations in Europe or those countries over there that are testing that you can do compressions while someone is shocking? I don't want to be involved with those studies. I don't want to test that out because then you might end up like Flatland Frank, my mannequin in my truck. Okay. Uh, after the shock is delivered, as soon as you hear the AED say shock delivered, immediately resume your compressions, starting compressions. Yeah, I don't want to become a patient myself, man. That would suck. So immediately resume compressions. If the AED tells you no shock advised, if the AED says no shock advised, you will continue with your compressions immediately. Okay? You immediately resume your compressions. Any questions on AED or defibrillation? Make sure you place the pads where they go. Patient's upper right, patient's lower left, not your view of the upper right or lower left. Patient's upper right, right below the clavicle above the nipple line typically, and right along the anterior lateral line right below the nipple line, left-hand side of the body. Let's see here. Questions so far? How are we doing? I don't have my water or tequila with me, so I gotta be dehydrated for a minute. Let's see. Okay, I probably got about, can't remember how many slides I'm on, but we're almost done. Okay, moving on. Advanced airways. This is for advanced EMTs only. Advanced EMTs only or above. Okay, if you are a military service member and you are a medic through the service, you can do advanced airways because most military service providers are not technically advanced EMTs, but their protocols recognize them as such. Yeah, it's definitely interesting to learn in case you go for your advanced or your medic there, BSI. So, advanced EMTs, they go to the base, or sorry, they meet up with the glottic opening and or go past them. If you are an advanced EMT, you will not be doing endotracheal tubes, or ET tubes, unless your service trains you and specifically says yes, which I have not heard of that happening. Most of the time, you're going to go off your local protocols. If your service says you cannot do these things, you will not do them. Okay, if your service says you cannot do these things, you will not do them. If your service says you will do these things, but you're not comfortable doing them, challenge that. Say, I don't think I should be doing that. That is outside my scope, because you should be going off the scope of practice that's written by the NREMT with your state EMS office as well. So supraglottic airways. Supraglottic airways go to the supra, which is the superior portion of the glottic opening, or the top side of the glottic opening, like the King, LT, or LTD, LMA, as well. Sorry, the King, LTD, the LMA, or the iGel, which you see in this picture. iGels are amazing. We used to use them overseas a lot, but they sat in the Connex boxes for a while and they started to melt because they sat there forever and the material inside was melting. So that's why we were kind of shying away from those. We're either doing OPA and PA or moving straight to the crike, which is crazy to me, but I get it. I don't want to be one patient that gets a crike, though. I won't volunteer for any of these practices. I've gotten a few NPAs in my life during training. I'm not going to volunteer for these. I'm not the Navy, so. Let's see here. If you are using an endotracheal tube, make sure you use capnography as well. Capnography measures the end tidal CO2. So end tidal, the end of your breath. With each breath you take in, you have a breath out, hopefully. And it measures how much carbon dioxide you are exhaling with each breath. The normal range for carbon dioxide end tidal CO2 is 35 to 45 millimeters of mercury. 35 to 45 millimeters of mercury is the gold standard. That's where you want to be. And does anybody know what your normal blood pH is? What is your normal blood pH?
7.35 to 7.45.
Fantastic. 7.35 to 7.45. Oh my gosh, 35 to 45 millimeters of mercury for your carbon dioxide, which is an acid, versus 7.35 to 7.45 for blood pH. Woohoo! It lines up. It makes sense. It's connected. Okay, if some patient is not breathing properly and you see that end tidal CO2 number or that capnography or the capnometry going down, it's decreasing in numbers. What is happening to that person's blood pH? Is it dropping or is it going up? It can be for anybody that wants to answer that one. So if a patient's not being ventilated properly or in cardiac arrest, end-tidal CO2 is hooked up and the number is dropping on there. You're seeing it drop down to like 10, 12, 8 for the millimeters of mercury. What's happening to their blood pH? Is it going down or up?
Katie, you want to answer? I saw you on mute.
Oh no, go for it. I literally clicked it as soon as I heard somebody else's, so go for it.
The lower the number and for the pH for the blood, the more acidic it gets.
Absolutely. So as the ventilations are becoming less effective, you'll see the entitled CO2 dropping because the body's holding on to all that carbon dioxide. So the blood pH is going to drop because the acid base scale goes from 1 to 14. Acid being as acidic as you can go at 1 and basic or alkaline at 14. And your blood sits at the perfect little balance, 7.35 to 7.45. So if your body's becoming more acidic, you're going to see the entitled CO2 number drop because their body's holding on to all that. Because what that entitled CO2 measures is how much your body is releasing with each breath. So if you are doing CPR on a patient and you have capnography hooked up, BSI, do you know what number you should see for the entitled CO2 if you're doing adequate ventilations? I don't expect you to know this, but if you do it, fantastic. Let's see if BSI knows. If he doesn't know, we'll pass it on to somebody else, see if they know. Let's see.
Can I take a guess?
Absolutely, you can, Katie.
Okay, so is it 10?
It's around 15 to 20 is what your goal is. If you see it start to drop
Okay.
below that, especially below 10, you realize, oh shit, I'm not doing my compressions or ventilations properly.
Okay.
I need to readjust because the body is typically really great at getting rid of CO2. If you're doing compressions and their cardiac arrest and ventilation support, you are manually doing that for the body. It's not going to be as effective. That's why we don't expect the number to be 35 to 45. We expect it to be lower, but not as low, below 10. 15 to 20 is your goal. You're good. You're good. BSI 14 is I would have been happy at 14, but if you just start to drop below 10, you realize you're doing something wrong. You need to readjust. Now, if you see a giant spike in the end tidal CO2, so since we went the opposite way for not good ventilations, and we see a giant spike in that capnography, what do you think that means? Can be for anybody. Oh, my back. BSI, you want to take a shot? Not of tequila, but at the answer. So if you see a giant spike in that capnography or capnometry, yes, Kings are AEMT in our area for NREMT at least. It depends on your local protocols. You can do supraglottic airways as an AEMT per registry standards, but it depends on your local protocols. So if you see a giant spike in that capnometry or capnography, it is usually a sign of ROSC, which is return of spontaneous circulation. Usually means the body is perfusing itself now. It does not mean they're fully awake. It does not mean they're fully alive, but it means their heart is starting to perfuse itself, perfuse the body again. That's a good sign to do a breathing and pulse check to see how well the breathing as well as how well the heart is beating. If you get ROSC, woohoo, we can celebrate. Okay? Oh, not there yet. If you get ROSC, we can celebrate. If not, we'll talk about that later on. Okay. As an AEMT, there are medications you can help administer. Depends on your local protocols. Okay. The two most common drugs you will administer as an AEMT is epinephrine and amiodarone or lidocaine. I see it more amiodarone more so. Okay. Epinephrine and amiodarone. Epinephrine dose, the first initial dose will be 1 milligram. Okay. Epinephrine, the first dose is going to be 1 milligram of epinephrine. Typically, how it's going to go is you're going to shock twice. So, shock. Wait 2 minutes before you shock again. Shock. And then as soon as you deliver that second shock, you're going to hit them with the epinephrine. Okay. And then 2 minutes later, when you shock again, you're going to shock and get that first dose of amiodarone ready. Anybody know the first dose of amiodarone? Maybe a Viking, since I think he's a medic as well. 300 milligrams, fantastic. Woo! Initial dose. Oh, you're a basic Viking? Okay, no worries. Initial dose of amiodarone is 300 milligrams. That's for the initial dose. So shock, shock, epi, shock, amiodarone. Guess what's next? Shock. And 2 minutes later, you're going to deliver another dose of epinephrine if needed. Hopefully, it doesn't take too long to get to the hospital by now. Okay, so your shocks are 2 minutes apart. You can give medication you can give epinephrine every 3 to 5 minutes, and you can give amiodarone every 3 to 5 minutes. Okay, so if you're alternating with each shock, you're giving a different drug medication, they're gonna be 4 minutes apart. So it lines up beautifully. Okay, it lines up beautifully. Sometimes when epinephrine is administered, they follow bicarbonate. What's the bicarbonate for? I personally don't know that answer. I don't know the one for the sodium bicarb. I think that's more of a medic level or paramedic level. I have not seen that one given personally. So I'm not gonna speak to things I don't know. But I will look into that and get back to you, Viking. Viking, if you want to join the Medics After Dark Discord and ask that question, you can. Here is the Discord server for Medics After Dark. Introduce yourself, claim your role, and make sure you behave, or else you will be muted or banned, or worse, expelled. Okay, so back to it then, right? So, shock, shock, epi, shock, ami, shock, epi, shock, ami. Your second and subsequent doses of amiodarone are going to be half of the initial dose, 150 milligrams. Okay, so your initial dose of amiodarone is 300 milligrams. Every dose after that will be 150 milligrams per your local protocols, and I've not seen that change. It's always been the initial dose 300 milligrams. Every subsequent dose after that, 150 milligrams. Your epinephrine dose does not change. It is 1 milligram. And make sure you are using the ratio 1 to 10,000, not the 1 to 1,000 ratio. 1 to 1,000 ratio is set up for epinephrine. If you give them 1 milligram of the 1 to 1,000, you will kill your patient. Don't do that. Bicarb, also known as sodium bicarb, is what our buffer system is for what helps keeps the hydrogen at bay. Nice. Appreciate that, B-Town. Yeah, and Viking, B-Town is in the Discord server as well. So definitely ask questions as needed. This is a great community that I've joined like last week or so. So if you're shock, way to memorize the order of operations for shocking with drugs. Shock, shock, everyone, shock, always. So shock, shock, epi, shock, ami, or amiodarone, shock, epi, shock, amiodarone, shock, ami. You're giving medications every 2 minutes, and there's alternating, which is perfect with that range of 3 to 5 minutes per drug. So I learned that from one of my cardiologists, and when I was getting my ALS instructor license. Naloxone EMT basics and advanced EMTs can provide. Naloxone, otherwise known as Narcan for the trade name, is an amazing drug. Imagine it only works for opioids, though. Only works for opioids. If you try to give it to a patient that's not on opioid overdose, it will not work. Okay, opioids only. But Mr. S or Heathen Medic, what if I don't know they're on opioids? If they meet the criteria of the opioid triad, it's not on here, but I like to talk a lot. Opioid triad is 3 things you look for. Pinpoint pupils means their pupils are very constricted, very tiny. Okay, pinpoint pupils, respiratory depression. It means they ain't breathing right. They're not breathing well. Respiratory depression and severe sleepiness or unable to arouse or wake them up. Mental status. That is the opioid triad. 3 things. You can suspect that they're on opioids. And you can administer Narcan, which Narcan acts as a competitive inhibitor, which means it knocks the shit out of that opioids and takes the place on that cell receptor. It does not last long, though. Naloxone is a hell of a drug, but it does not last long. It has a very short half-life and it'll wear off within minutes. Okay, you can administer every usually 2 to 4 minutes if needed. So, because there's usually a lot more opioids in the drugs than that Narcan lasts. Does not get it out of the system. All it does is boots it from that cell receptor so it's not affecting the body as much. but the Narcan will wear off, or naloxone will wear off, and the opioids will fill that receptor again and send them back into that respiratory depression and/or cardiac arrest. Now, question for the kids. Viking, if you want, you can hop on the Discord and hop on one of the live chats later on, the voice chats, and you can ask a question. Maybe they can explain it better over voice. Uh, question for the masses. I had a question now. I forgot what it was. I can't remember what the question was going to be now. Fantastic. Oh, here's another one for y'all. What is the only contraindication to naloxone? Anybody know the only contraindication to naloxone? Vasodilators? Not really. I wouldn't really worry about that too much. The biggest contraindication is hypersensitivity, means they're allergic. How the hell are you going to know that? You're not really going to know it unless you try it. Unless they got a tattoo that says no, allergic to Narcan, I'm going to give them Narcan if they need it, or naloxone. Now I remember my question from earlier. If you come across a patient that's in cardiac arrest or respiratory arrest, but you know it's opioids or you suspect it's opioids, what do you give first? CPR / ventilations or Narcan? Viking, you're probably thinking of nitroglycerin. So if you come across a patient, their H's and T's, yep, nitro, that's it. So you're going to do cardiac arrest support, so CPR, or ventilation support while your partner gets the naloxone ready. So initial life support measures are the CPR / ventilation support. And then you can give naloxone as soon as it is ready. Unless you have naloxone in your hand as you're walking up, ready to go, I'm providing ventilations and cardiac arrest care if needed. For those that have given atropine before, it is one scary drug. Okay, it is one scary drug. But I'm not going to talk about atropine today because that is above my scope for my level. Okay. Special considerations. If you have a patient that is pregnant, that is in cardiac arrest, that is at least 20 weeks pregnant, you will do something called left uterine displacement. Anybody want to hop on the voice chat and tell me why you need to do left uterine displacement? Ooh, hit my computer.
To displace the fetus off the inferior vena cava.
Yes, to get the uterus.
To allow the blood flow. Yeah, to allow blood flow to continue.
Fantastic. Yes, I love educated people. It gets the weight of the uterus and the fetus off the inferior vena cava, which is the big ass vein that's returning blood to the heart from the lower half of the body. Because the baby in the uterus has a lot of weight to it. So if you let them lay on their back, that's going to compress that inferior vena cava. So you need to do something called left uterine displacement, which means you need a team for this. You have one person on either left or right side of the patient, and you're grabbing the uterus or around the belly, and you'll pull that uterus and the weight to the left side of the patient's body and up. I call it left up displacement or left uterine displacement. Pull it to the left and up. That displaces it off the inferior vena cava, which helps the blood to go back to the heart. So your CPR is not futile. Now, if you're like, oh my gosh, I can't tell how far along they are, which happens a lot because some women don't show as much, and some women, you can't ask them if they're unconscious how far along they are. You'll measure something called the fundal height. Okay, if they look pregnant, though, you can probably just do left uterine displacement and be safe. But it's usually at 20 weeks or greater. You find the fundus, which is the top muscle, the top part of the or the superior portion of the uterus. It's a lot denser muscle. You would palpate and you would feel it. If it's at that belly button or umbilicus or above, you can consider them to be 20 weeks or greater. And that's when you would do left uterine displacement. Let's see here. Oh, I need to go back to my lab. There we go. Oh, try again. There we go. I haven't clicked on my live in a bit, so it was saying, oh, where are you at? Fundal height again, absolutely. So if you are checking the fundal height, not fungal, fundal height. So palpate around the abdomen. I'm not sure how well how low you can see my body. Let me see here. See what you can see on the camera. So find the belly button. So if you find the top of the uterus, which is the fundus, is at the belly button or above, you can consider them to be at least 20 weeks. If it's below, they're probably less than 20 weeks. So you're palpating, you're finding the top dense part of that muscle in the uterus and figuring out where it's going. If it's at 20 weeks or greater, you're probably going to see it go up or above. If it's below, it's probably less than 20 weeks. Absolutely, Viking. And even if you get ROSC, even if ROSC is achieved, you must continue left uterine displacement until the mother has resuscitative cesarean delivery, which means they're getting a C-section. They'll be getting a C-section if they go into cardiac arrest while they're pregnant or 20 weeks or greater, because that baby needs more medical support now after the cardiac arrest incident. So you will hold left uterine displacement until they are at the hospital and that resuscitative cesarean delivery is performed. We already talked about pediatric considerations, trauma. I'm probably going to worry about trauma over cardiac arrest. If they're bleeding out, I'm going to stop the bleed and then do compressions if needed. If you can provide spinal mobilization, please do. If not, move on. Hypothermia. If the patient is extremely cold, hypothermic. I'm trying to allow others to answer. Oh hell yeah, you're good, B-Town. I appreciate you. You getting a paramedic soon? Hell yeah, dude. Congrats. Hypothermia. We have a saying: they're not unalive until they're warm and unalive. So if they're cold, warm them up. And if they're still not responding after that, then you can consider them kaputs. But if they're hypothermic, you have a good chance of saving them if you get them fast enough and provide resuscitative care. With drowning patients, you're going to primarily focus on oxygenation and ventilation, provide a lot more aggressive ventilation. With drowning patients, if you have a drowning patient or victim, CPR always starts with compressions, except for one caveat here with drowning patients. If the patient was drowning, where's my mouse? I can't see my mouse. Patient was drowning, that's the time you will start with 2 breaths first, or 2 attempts of breaths, and then you will go into CPR, regular cardiac arrest care, which is compressions. Any questions so far? And I'm thinking about going for my Medicare soon there, B-Town. Let's see here. Let's go. Yeah, I'll be pursuing that soon after I finish my master's. Can't do too much at once. Okay, teamwork. I like this meme. One does not simply make the dream work without the teamwork. Make sure you have clear roles. If you have someone that has shoulder issues or hip issues, probably keep them off the compressions if you can. Make sure you have closed-loop communication, which means if your team leader gives a task to you, you repeat back the task. I will do this, and repeat what the task was. And whenever you have completed that task, you report back to them and say the task has been completed. Debriefing is done after the post-resuscitation. You're not going to debrief while you're actively providing care for the patient. That does not work well. I don't recommend it. And respectful communication. Use a calm and professional tone, if I can speak tonight. Sorry, I've been talking for 7 days. I'm exhausted. Okay, calm and respectful tone. Documentation, document everything you do. Hopefully you have a recorder available. If not, your AED slash your Zoll monitor typically records all the care you provide. You can push buttons on there sometimes to record, document what you've done, like medications, shocking, compressions, ventilations, etc. Make sure you use what your jurisdiction and local provider and local protocols say to use. One of my favorite slides here, success. If you are response or patient, if you achieve ROS, congratulations. Maisie, one of our admin mods in the Discord, recently got her first ROSC in the past 5 years, so that's amazing. Good job to her. Treat the underlying H's and T's. Okay, H's and T's. It is an acronym that helps you understand things that are causing it, like trauma, hypovolemia, hypoxia, hypothermia, etc. I'm not going to go through the full list right now. Just because you get ROSC does not mean the patient's fully awake or breathing by themselves. So you might need to consider, or you might need to continue doing airway care, ventilation care. If they're not conscious yet, you could consider therapeutic hypothermia, also called targeted temperature management. That keeps their body a little cooler while it heals itself, pretty much. In simple terms, that keeps the body cooler while it is healing itself. That is the goal of it. Keeps the body cooler while it heals itself, because a body in anaerobic metabolism, which means without oxygen working for it, produces a shit ton of lactic acid, which is not good for the cells. Then if you flood it with a lot of oxygen, especially for cardiac or heart attack patients, it's going to produce free radicals, which is toxic to neighboring cells, which all my EMTs should know what. Yeah, no worries. It's all good. I'm talking a little longer than I planned to, but it's okay. I like teaching. Free radicals are toxic to neighboring cells. Okay. Here we go. Make sure what color is saline, clear, same as water, colorless, or give O2 in transport. I like this one. I've seen this one plenty of times in the past 13 years. So make sure you pay attention to what the question is asking you if you're taking registry. For your paramedic coming up there, B-Town, read the question carefully, understand all the choices, understand what it's asking you, and make sure you know that registry is going off AHA guidelines. Are there any questions? I'll give you all a minute to ask questions if you have them. Good stuff, very good. Appreciate that, man. I like teaching. Been doing it a while, so. Semi-related questions. How often do you do these lives? This is the first live I've done like this. If you join the Discord, you'll have other EMT providers, medics providing similar education things like this. They probably won't be doing it on TikTok all the time. A few people are on TikTok, uh, but I will probably try and do this maybe once or twice a month. I got a lot of family time. I spend a lot of time with my family, and this cuts into it, so I don't want to do it too often on here. So, but of course, if you have any questions, please feel free to message me on TikTok, Discord, however you want to. I'm the same name. I could be there in your lives to help when you can. Appreciate that, man. Appreciate you. Smiles. Well, if you have no questions, I'm going to end this live and go spend time with my wife and watch some Dr. Stone. And I'll probably drink some more tequila. So, questions. Thank you, and see you in Discord. Oh, yeah. Viking, join the Discord if you have not joined already. I'll send the link again. Here you go. Just so you have it. And B-Town, next time I'm going to get a little, you're in, perfect. I'm going to get a little QR code made to put on my TikTok live right here so people can join from there too. And actually, let me do something here. Let's see. How can I do this? There we go. There we go. Cool. Well, if you have any more questions, I'm going to head out. Y'all have a great night. Be safe. And love you. How do I end this live? There it is. Bye.